to welcome everybody to this session. I think it's the first of the pre-Congress sessions for IHEA. And this one is on tracking health expenditure during the COVID-19 pandemic. I think you have as well, and maybe we could put that in the chat, a link to the IHEA webpage, which has all of the bios for everyone and gives you an idea of the agenda for this time. We're going to have a mix of pre-recorded presentations and live discussion. And I will try to manage the transition from one to the other. So we're going to start with an opening presentation that is pre-recorded on setting the scene, which is really about the policy relevance of COVID spending and non-COVID spending during the pandemic. This will be done by Shu Ke, who's the Senior Health Financing and Expenditure Analyst at WHO and is leading the health accounts team here. So let's turn to that presentation. Thanks.
Hello everyone, my name is Shu Ke from WHO. Welcome to this session on COVID expenditure tracking. Before the amazing country case studies, let me first give you a preview of this session. I will quickly go through the questions on why we want to check the COVID expenditure, what we want to know, and how to do it. Tracking COVID spending is important for at least two reasons. First, for transparency and accountability. Second, for further investment in health system. The pandemic affected every single country. It threatens people's life, disrupts socioeconomic activities. Governments, civil societies, and development partners have been putting huge effort to control the pandemic. This also includes a significant amount of financial resources. Because of the scale of the pandemic and the sense of urgency, the money made available to the system may not necessarily flow the existing channel. This makes it difficult to see whether the resource is spent at the correct place. Tracking COVID spending will provide a more comprehensive picture to hold every single stakeholder accountable. Furthermore, the health system is the most heavily hit sector by the pandemic. The pandemic posed many new challenges. In the meantime, it also revealed the existing shortcomings of the system. The spending pattern during the pandemic will provide more insight to guide the future investment in health system to be more resilient, to be more prepared, and to contribute the overall health security. What do we want to know? I would here just illustrate three types of questions. One is on COVID spending. How much did the country spend on COVID? To what extent the budget committed were actually implemented? What interventions are the money spent on? Where does the money come from? And how is the money channeled? The second group of questions is on non-COVID spending during the pandemic. COVID is not just a disease. It's a huge interruptive event to the system. What is the impact on the non-COVID spending, such as immunization, such as HIV and TB control? Whether the essential services are compromised during the COVID pandemic. The third group of the question is about the health system or health financing characteristics in responding to the COVID pandemic. Does health financing structure have an impact on how quick countries were able to mobilize and to channel resources to the frontline providers? How to track the COVID expenditure? The first step is to define the activities that are related to COVID-19. This is guided by the WHO framework of the COVID-19 Strategy Preparedness and Response Plan, so-called SPRP 10 Pillars.
According to this framework, the following activities are counted as COVID spending, such as coordination planning, risk communication, surveillance, point of entry, laboratories and diagnostics, infection control, protection of health workers, case management, clinical operations, support of logistic and supply chain, maintain essential services, and vaccination. However, we need to take a note, data collected in 2020 do not include vaccination because this activity only started this year. You will hear more about these 10 pillars in the following discussion. Once the activities are defined, we apply the System Health Account SHA-11 to further map the expenditure. The SHA-11 is the international standard accounting framework for tracking health expenditure. In this framework, there are 3 dimensions: consumer, financing, and provision. Under the consumer dimension, it includes functions and beneficiaries. The financing dimension includes financial arrangement and the source of the funding. As of the provision, it includes the types of provider and the factors of provision. In the summary, we use the SPRP 10 pillar to define the activities that related to COVID, and then we would use SHA framework to map the expenditure. So we can separate the recurrent health spending and the capital investment. Among the recurrent spending, we can also separate the spendings according to function, such as treatment, testing, contact tracing, or by source of funding from domestic government, external aid, NGOs, and household. We can also identify the factors of provision, such as medicine spending or the HR spending, the salary spending. So you can see that the whole exercise is really through the data collection, data mapping, and analysis so that to fit in the policy discussion. In this session, we will also have panel discussion after the country case study presentations. The panel will talk about the effort in checking COVID spending at global or national level. What are the challenges that are specific for tracking COVID expenditure? What are the future efforts needed in data collection, analysis, and interpretation? What we can learn together and help each other. The world has never been so connected as demonstrated by this pandemic. What we can contribute as policymakers, development partners, civil societies, and researchers. I will stop here. I look forward to a very inspiring discussion. Thank you very much for your attention.
Very much, Shuka, and I think we're off to a good start to give us the overall framework and way of looking at these issues. Next section, we're now going to have start on some country and regional presentations, and the first will be from OECD on COVID-19 and the impact of health spending in OECD countries. And this is going to begin with a presentation from Michael Muller, who's a health policy analyst at OECD. And then it will be followed as a kind of country reflection from Canada by Chris Kuciak, who is the manager of health expenditures at the Canadian Institute for Health Information and oversees their national health expenditure database. So let's turn now to the OECD presentation.
Well, thank you very much, Joe, and welcome also from my side to all of you. We're very happy and glad that you're interested in this important topic. And in the next 15 minutes or so, I'm going to speak about the work done at OECD and in OECD countries on tracking health expenditure, and in particularly trying to measure the impact of COVID-19 on health spending 2020. So let me start by providing a quick overview at the tools to track health spending at our disposal. Mainly rely on our annual data collection that we carry out jointly with WHO and Eurostat based on the system of health accounts, which is an accounting framework built around three core dimensions: financing schemes, type of service, and providers, and which also defines health spending in an international comparable way. Nearly all OECD countries submit detailed health spending data according to this framework and the key three dimensions for all years up to T-2. That means at the moment we have data for nearly all OECD countries up until 2019. Around half of OECD countries also provide data for a year, preliminary data, I should say, for year T-1. So that means we have at the moment 15, 16 countries which already submitted data for 2020. All of this data will be published this week on July 2nd, Friday, in OECD Health Statistics, which also gives then a first indication of the impact of COVID-19 on health spending in OECD countries. But before looking at the data, just a quick reminder what we're talking about when we mean health spending in the context of the system of health accounts. So this chart here just provides a visualization of the system of health accounts framework, and I'm aware that you've seen this in the other presentation. Just very quickly, it is built around a three-dimensional accounting approach, so around the financing schemes, providers, and functions. So a system of health accounts also provides basically the boundaries. What is current health spending? And this refers to activities with the primary purpose of improving, maintaining, and preventing the deterioration of health status of persons, and also includes a list of ancillary services that should be included. In the aggregate of current health spending, capital investments are not included. Also, health-related expenditure, such as social activity in relationship to the provision of long-term care services, are also not included. On the other hand, you should be aware of a general accounting concept that is used in the system of health accounts. It means current health expenditure refers to the final consumption of healthcare goods and services, so it does not include directly intermediate consumption. And subsidies to healthcare providers should also be included in the aggregate of current health expenditure. And particularly in relationship to COVID-19, this has the last bit on to what extent subsidy or income support to providers should be considered subsidies or not, has proved to be a bit of a challenge. So this slide here shows you the first preliminary results, how health spending developed in 2020, also allowing us to assess the impact of COVID-19 on health spending. So this data you see here is based on preliminary estimates from 14 OECD countries. On the left-hand side, you see how the indicator health spending as a share of GDP developed over the last 15 years for those 14 countries. And you see in 2019 to 2020 a jump of this indicator of 1 percentage point, up from 8.9% in 2019 to 9.9% in 2020, similar to what we observed during the financial and economic crisis 2008-2009. And this is the result in 2020 of two trends. First, strong growth of health spending, and second, a widespread drop in GDP. In 36 out of the 38 OECD member countries, only Turkey and Ireland recorded positive GDP growth in 2020. On the right-hand side, then, you see basically the growth components, if we look from a financing perspective. So we see, on average, a total health spending growth per capita in real terms of 5% on average.
Hi, everyone. We're just having a moment of technical difficulty. Please bear with us.
Afternoon, good evening, wherever you are. I am coming to you live and in person from Canada. So I'm delighted to be with you and honored to be part of this panel discussion. We'll have an opportunity to see the slides, but I would welcome the opportunity to speak a little bit. My reflections will be a little bit more around the theme of when we look at health spending, what the pandemic has done is actually amplified pre-existing trends. And I'll give you some examples. Let's talk about, well, the importance of data. What we've seen is that during the pandemic, policymakers were looking for data to make decisions. Prior to the pandemic, uh, uh, Michael and Shuka talked about the system of health accounts, the standard for implementing international comparisons for health spending. And before the pandemic, we talked about improving the timeliness of the data. We talked about closing data gaps in the areas of long-term care, primary health care. So, these were areas that were now, this data was in high demand, obviously, as the pandemic hit. A second area or trend that was pre-existing that I wanted to highlight is, if you recall, prior to the pandemic, most countries around the world were running deficits. And what we were seeing is that health spending was growing rather modestly, either comparable to economic growth or even slightly below that, as countries were trying to balance their budgets, restrain fiscal spending, and healthcare was a part of that. Now, of course, during the pandemic, we've seen these huge deficits that countries have run in order to support their populations, in order to support their economies. So the challenge going forward now will be, how much can we afford to invest in the healthcare system, given that countries are now in huge deficit positions, and there are other priorities to deal with as a cause of the pandemic. Think about climate change. Think about reskilling the workforce. Think about technological infrastructure investments. So there are a lot of other priorities out there that governments will be grappling with. And the second question that policymakers will have to try to think about is, how do we spend differently so that we can make the healthcare system resilient, so that when the next pandemic hits, we don't have to shut down the economy and lock everyone up in their homes. And so how do we spend differently will be an important question. And having the data to look at where are the priority areas in the healthcare system. So I think those were a couple of things. I'll just pause.
Very high growth in health spending 2020 in real terms in Estonia, more than 15%, also very high in the United Kingdom and Slovenia. On the other hand, Chile, Portugal record negative growth in 2020 based on their preliminary data. We also see a reversal of spending growth in a few countries. So Korea, for example, very high spending growth in 2019, more than 10%, down to 2% in 2020. Lithuania, similar case, health spending growth in 2020 only half what was observed in 2019. On the other hand, Ireland, United Kingdom, Slovenia, and Estonia, in those countries, health spending growth was more than double in 2020 what was seen in 2019. And health spending development in 2020, as I'm sure you know, combines basically two opposing effects related to COVID. On the one hand, we observe additional expenses due to preventive activity, preventive measures, widespread testing, tracing, and also treatment of COVID patients in inpatient setting, where especially when it involves the use of intensive care capacity or ventilators will be then very, very expensive, but also treatment in outpatient care and pharmaceuticals would obviously have an upward pressure on health spending in 2020. On the other hand, we also observe a widespread disruption of services and reduction in service use and postponement of non-urgent care in many, many countries. So on this chart here, I just want to highlight that the service disruption may actually have a negative impact on health spending on an aggregate level, but also may depend on the financing system or the payment system for providers in place. So on the right-hand side, you see some data from the social health insurance scheme Belgium. It refers to billed hospital expenses in 2018 to 2020 by month of service provision. You do see that in green here, the year 2020, the billed hospital bills were high in January and then going down rapidly to April, and before increasing again. But you do see that the hospital bills, and that may reflecting a reduction in hospital activity, but it's much lower in March, April, May in 2020 compared to 2018, 2019. So this type of service disruption happened in the first wave in many OECD countries, widely documented in GP specialist consultations, elective surgery, cancer screening, or emergency visits. And in health system with activity-based funding, reduction in activity will translate in reduction of revenues of health providers and may lead to reduced health spending overall, unless there's some financial support mechanisms or subsidies to health providers in place. So in countries without activity-based funding, where basically you've got the budgets which are covering the input cost, this would not necessarily be an issue. So this is something I think we should be analyzing further, to what extent there may be a difference in health spending 2020 based on the payment system in place in countries. It's certainly something would be quite interesting to follow a bit further. In addition to measuring overall health spending 2020, we also attempt to measure direct health spending for COVID-19. And this is part of some exploratory work we started this year. We asked countries to identify 5 COVID-19 spending items within current health expenditure, a part of their regular data collection. And these refer to treatment costs for COVID patients, the cost for test and tracing, vaccination costs, cost of medical goods, and other COVID-related health spending that are considered as current health expenditure. And we also asked them to report on 2 additional COVID items which are outside of current health expenditure, referring to provider support, which countries choose to not classify subsidies because these would be considered as current health expenditure, and investment costs. And here we see data, preliminary data from 5 countries that are in a position to report the majority of these health spending items. You see quite a variation across countries. Some of this may be justified because obviously some countries were hit harder by the crisis than others. But there's also reason to believe that some of it has to do with data availability and accounting principles applied. So, for example, we see a wide variation within current health expenditure between Germany. So if you just stack up the blue items here, which refer to the 5 COVID spending items with a part of current health expenditure, reflecting 1.6% of public health expenditure, and this ranges up to 9.6% of public health expenditure allocated to COVID in Ireland. So quite a substantial variation. And also, you see in Germany, so the biggest spending item is actually, or COVID spending item is actually outside of current health expenditure, referring to provider support payments. So it's certainly encouraging to see that a number of countries are able to report spending on COVID-19 in 2020, although we know there is still a bit more work to be done to better understand the data, the accounting principles applied, and to improve the comparability of the data. Substantial increases in health spending can also be observed when analyzing supplementary COVID-19 budgets. And this is what can be seen on this chart. So some of my colleagues estimated health allocations in supplementary COVID-19 central budgets as a share of GDP for a number of OECD countries. And similar to what we saw when looking at health spending growth, we see in some countries quite substantial new resources made available in 2020. So, for example, the United Kingdom here, very significant increase in health spending allocations. Also one of the countries with the highest overall growth rates in health spending 2020. Also similar, I think, to the chart I've shown you earlier is the high variation across countries, which we also observe in the difference in growth rates 2020. However, a word of caution when analyzing this budget data or looking at this budget data here, these refer to central budgets. It may not show the whole picture since regional budgets and state budgets or municipality budgets are missing. Data here refers to approved budgets, which is not the same as executed budgets. Nevertheless, the budgets here, if we analyze this data, is we need to admit that they go beyond current health expenditure in SHA, since they're wider in scope, and thus can provide complementary information on COVID-19 response costs. For example, if you look at information on funds allocated to vaccine research, you will not be able to find this within the scope of current health expenditure in SHA. So looking at budgets obviously makes sense to get complementary information. So this is just a summary of the key takeaways of my presentation. First, the SHA 2011 framework is a very appropriate tool to track health spending and assess the impact of COVID-19, but you need to be aware that some of the transactions are outside of its scope. Second, and coming to results, health spending growth in 2020 in OECD country is projected to be similar to 2019, around 5% in real terms, and with quite a big variation across countries. Health spending share of GDP is expected to jump by 1 percentage points, and while we observe strong growth of government spending, in most countries we see a drop in private spending. Third, and this is a hypothesis which we certainly need to analyze a bit further, is countries with activity-based financing may record more limited health spending growth in 2020 due to widespread service disruption. And fourth, the identification of these new COVID-related spending items seems feasible in a number of countries, but certainly a bit more work needs to be done there. I would like to invite now Chris Kuczek from the Canadian Institute for Health Information, who is also the chair of the OECD Working Party on Health Statistics, to provide a few comments on the presentation and provide his perspective on those findings. Chris, the floor is yours.
Good. Chris, did you want to come in again? Please go ahead.
I would just say my last comment was that what will also be interesting to see going forward is separating out sort of the temporary response spending versus the more permanent shifts in spending going forward. So that hits to my point about how we will see shifts in spending going forward in order to better prepare for the next Black Swan event. So I'll stop there and I'll hand it over to you, Joe. Thank you.
Great, thanks. I can't help myself but reflect just very briefly on the point Michael made about the hypothesis around activity-based funding. What we can say, I think, and what is important is that in some countries, it's not even an option to use, or it's not a policy option to use payment in a way to move away from that activity-based funding because coverage is incomplete or systems are too fragmented. So this gives an idea of what that level of fragmentation would be an obstacle to be having a more resilient system. And having at minimum a unified payment system would be an enabler for that. But that's the last speech for me because we're moving on now. So next we're going to have some presentations from the Africa region. And that's going to start with Juliette Nabianga, my colleague in the regional office for Africa, who's leading the health financing and investment program. She'll be followed by Kingsley Ade, who's leading the health financing work at the WHO office in Ghana. And last, we'll hear from Aja Tiane Guia Dia, excuse me for the pronunciation, who's coordinating the health economics unit at the Ministry of Health and Social Action of Senegal. And his talk will be in French. So just a reminder to use the Wordly for translation if you need that. So let's start these presentations.
My name is Juliette Nabianga, and I work for the WHO Africa Regional Office based in Congo, Brazzaville, where I head the Health Financing and Investment Program. I'm pleased to be speaking in this IHEA conference, and I'll talk to you about the COVID-19 health spending in a few selected countries of the WHO African region. What have we seen from our COVID expenditure tracking studies, and how does this compare to non-COVID spending? I'll give a brief background to the expenditure studies we have undertaken. I'll talk about the methods, and I'll go on to present country results, and I'll summarize with the key considerations for all of us. Turning to the background, the main objective of undertaking these COVID-19 expenditure tracking studies in selected countries was mainly to provide information on COVID-19 financial flows from March to December 2020. We chose the month of March as the starting point because this is when the countries under study reported their first case. This evidence was envisaged to guide planning, allocation of resources, or even reallocation if need be. The selected countries were 3, Ghana, Senegal, and Burkina Faso, and the number of confirmed cases by 30th December is shown on the slide. Ghana slightly over 92,000, Senegal slightly over 40,000, while Burkina Faso was slightly over 13,000. When it comes to raising funds for the COVID-19 response, the first port of call were the governments themselves, and they employed several measures to raise funds for the response, as we can see from the slide. Some established special funds for COVID-19 response, some had one fund, while others had as many as 3 or maybe even 4. Some reallocated away from non-priority spending, asked for supplementary budgets, while a few drew from contingency or reserve funds. Our countries of study, as I'll present in the results section, were Burkina Faso, Senegal, and Ghana. And we see that Burkina Faso and Senegal established special funds, while Ghana reallocated away from non-priority spending and also drew from supplementary budgets. Turning to methods, we followed the system of health accounts framework as much as possible. Of course, with a few adaptations to take into consideration the specifics as they relate to the COVID response. For example, under the provider category, a consideration for COVID isolation facilities, which is not part of routine service delivery. And we collected data from the different actors, the government expenditures we drew from administrative records, looked at regular reports, COVID response progress reports, and health financing documentation reports. Forms were sent to providers to provide the required expenditure data. We surveyed NGOs and corporations, engaged donors to get data on disbursements and expenditures. But we also looked at the global donor database to try and reconcile especially the disbursement figures with what is reported in the global database. An attempt was made to collect household expenditure data in Burkina Faso and Ghana, but not in Senegal. And the figures we have are a gross underestimate because we couldn't undertake the household surveys like we usually do because of the restrictions around the COVID pandemic. In Burkina Faso, the items that are purchased by households as part of the COVID response were taken into consideration and estimated the requirements per person. While in Ghana, the expenses were limited to testing and only at ports of entry. We now move on to country results, and I start with Ghana. The total expenditure on the COVID-19 response amounted to slightly over $1 billion, which translates into a per capita expenditure of $34. More issues for us to note: the significant role of the government, with a contribution of 89% of the total expenditure on the COVID-19 response. Again, we note the role of the private sector, and we need to build on this momentum as we build resilient health systems. How do we meaningfully engage the private sector to finance health services? The estimation from households is a gross underestimate due to methodological limitations. How does COVID spending compare to current health expenditure? We look at this in per capita terms. We look at the current health expenditure per capita for 2018 for Ghana, that was $78. We note that per capita expenditure on COVID-19 is 44% of the current health expenditure using the 2018 figures. We also looked at expenditure by response pillars. You'll note that here the pillar on continuity of essential health services is missing because that was added much later. The pillar on port health is also missing because it's lumped up with the surveillance. However, we note that the two pillars accounted for 79% of COVID spending, laboratory and IPC. Infection prevention and control at 44%, and the cost driver in here were the PPEs. Laboratory services at 35% of COVID spending is because of the expenses that are attached to COVID testing in Ghana. The cost of testing in Ghana is much higher compared to other African countries. What services were purchased? We note that 42% of expenditure was on ancillary services. And here we have the laboratory, we have the hotel facilities for admitted patients, and we also have the patient transport costs. 36% was on curative care. This is for admitted patients, not patients who are on isolation or for follow-up. These are under preventive services. I now turn to Senegal. We see much lower levels of spending compared to Ghana. Total expenditure on COVID amounted to $267 million, translating into a per capita expenditure of $16. Again, the significant role of the government, of course, much lower than Ghana, that was at 89%. In Senegal, we see that 54% of these expenses were paid for from government sources. Again, we see the role of the private sector that we need to harness going forward. How does COVID spending compare with current health expenditure? Again, we look at this in per capita terms. We look at the current health expenditure per capita in 2018 and compare this with the COVID spending. And we note that the per capita expenditure on COVID is 27% of the current health expenditure, much lower than what we saw in Ghana, that was at 44%. The expenditure by response pillars, again, is shown on the figure below. And we note that the supply chain accounted for 76% of total COVID spending. In here, we have the PPEs, we have some diagnostic equipment, and perhaps that explains the high percentages because ideally some of the costs would have been under labs. What services were purchased? We see that the highest expenditure was on governance, health systems administration, and funding, accounting for 47%, followed by prevention, which included IEC risk communication and surveillance, that accounted for 31%. We now turn to the third country, which is Burkina Faso, and we see that total spending on COVID response amounted to $348 million, which translates into a per capita expenditure of $17. Looking at the different sources, again, we see the significant role of the government that contributed 79% of total spending, higher than what we see in Senegal that was at 54%, but lower than Ghana that was at 89%. Again, the private sector playing a role. The contribution of households is a gross underestimate, again, because of methodological limitations. We again compare the expenditure on COVID to current health expenditure. In the case of Burkina Faso, we note that the COVID spending is 43% of current health expenditure in per capita terms. Turning to expenditure by response pillars, we are not able to provide a full disaggregation by all response pillars because of the way the accounts are structured. A lot of it is lumped up, and we cannot get a full breakdown by all the response pillars. We, however, note that the coordination pillar accounted for 64% of total spending, and in here, surveillance is included, food distribution is included, economic stimulus packages are included, and also incentives for health workers. Perhaps that explains the big percentage, but also it limits us in the extent to which we can look at expenditure by the different pillars of the response. What kind of services were purchased? We see that 80% of total COVID spending in Burkina Faso was on coordination and governance. But as I mentioned earlier, that there are data limitations, because in here we have the food distribution and the economic stimulus packages, which ideally would be coordination and governance issues. And that explains the high percentages because so many things are lumped up in there. And we see the low spending on prevention services, which also includes the surveillance, at only 14%. Does the level of burden, as shown the number of confirmed cases, relate to the level of expenditure that we see? Of course, that will be a very difficult decision for us to make given the data quality concerns, and perhaps we also need more explanatory data to try and make conclusions around that. However, we note that Ghana, that had the highest number of confirmed cases by December 2020, again had the highest per capita spending. And this is followed by Burkina Faso and then Senegal at $16 per capita. Again, I want to come back to the role of governments in funding the COVID-19 response. We see significant contributions. I hope we can all reflect on how we can build on this momentum to raise funds from governments to build resilient health systems, health security, and ensure attainment of universal health coverage. I'll now conclude with a few key considerations. 1. The significant role of the government in funding the COVID-19 response. We need to build on that momentum to raise funds from the government to build health security and resilient health systems. Corporations and the private sector are key players, and we need to bring them in. We need to harness that potential to expand provision of health services, but also to align their spending, their funding to health sector priorities. The figures that I have presented are not audited expenditures, and these may change once the accounts are audited. Figures are underestimate, and as I mentioned to you before, for example, households, the restrictions around the pandemic could not allow for proper household surveys. Comparative studies are still a challenge because the expenditures are organized differently, the providers are varied, and the scope of the response is varied. The financial reports are organized differently for the different institutions and agencies, and that makes it difficult to get very good disaggregated data to analyze what you exactly want to analyze. For example, by response pillars, by functions, by providers, the way the expenditures are lumped up makes that difficult. So we need to refine tracking methods as part of building resilience. We need to incorporate expenditure not only for COVID, but for emergencies into routine national health accounts, such that we can track expenditures on emergencies and we can make a case for investing in health security. I want to thank you so much for listening to me. I'll now pass on the floor to two of my colleagues. The first one to speak will be Kingsley Adai, who is our health economist in the WHO Country Office of Ghana. And he will talk about the policy relevancy of this kind of evidence. What policy questions have been answered in the case of Ghana by the COVID expenditure tracking exercise? And what decisions has this evidence influenced? Thereafter, I'll pass on the floor to my colleague, Aja Fiani, who is from the Ministry of Health in Senegal. Aja leads the National Health Accounts team in Senegal. And he will talk about the challenges as they relate to the process, challenges in data collection, and how we can improve the process. Over to you, Kingsley. Thank you.
Yes, for inviting us over. We are grateful. My name is Kingsley Adai-Frimpong, and I'm a technical officer, health financing from the Ghana WHO country office. Clearly, I mean, in the midst of the challenges associated with the rapid assessment, there are positive stories we can share. So if you look at the first issue that we are looking at, whether policy questions have been answered through the expenditure tracking. Just a caveat, a quick one here to say that the report, the final report actually came out end of May. And so I won't necessarily connect all of this point to the tracking, but really looking at it from the COVID-19 perspective. So the report has indicated that the government of Ghana, working with development partners and the private sector, mobilized more than 5.8 billion Ghana cedis, both in cash and in kind, to address the COVID-19 pandemic. This is about equivalent to the health sector budget for that year. About 93% of the funds were from domestic sources, and this is critical, of which 90% were provided by the government of Ghana. The private corporate sector responded by raising approximately 128 million Ghana cedis in donations. And again, the private sector raised funds to construct a 1,000-bed infectious disease hospital. And through the establishment of the Ghana Private Sector COVID-19 Fund, similar centers were constructed in strategic positions within the country using the Private Sector COVID Fund. So clearly, I mean, obviously, it tells you that the issue of domestic resource mobilization and the role of the private sector in health service delivery has actually come up again. What are the opportunities available to the private sector to mobilize sustainable resources for health? A quick point from the just ended annual health summit, which ended early part of May, indicates that there are 4 key issues that the government is looking at. One, the first one is the revision of the national health financing strategy to align with the USA roadmap, which was launched in late 2020. Now, in this whole process, attention will be given to making sure that we have a holistic, domestically coordinated transition and domestic resource mobilization plan. The policy, the health strategy will also look at mechanism for establishing a health fund for public emergencies and co-financing for vaccines and immunization. Coming out of the health summit, the ministry is also looking at collaboratively working with relevant stakeholders to develop and revise the private health sector policy. And this whole process is within the context of the new health policy, which is very, very heavy on social determinants of health, where multi-sectoral engagement is so critical. There is also the need for the health sector to operationalize the Ghana Beyond Aid policy statement. The Ghana Beyond Aid is a national transformation agenda comprising a vision of the Ghana we want and the mindset and behavioral changes that we Ghanaians commit to make in order to pursue the vision. So the vision calls for transforming the economy, which is now based mainly on the production and export of raw materials, to one based on manufacturing and high-value services That is an economy that provides opportunities, jobs, and prosperity to all Ghanaians. And if you look at the demand for local production in the context of PPEs during the COVID-19 intense period, that really tells you that there's a need for us to carefully look at some of these issues. Now, coming back to the issue of the policy decisions that have been made or likely to be influenced by the COVID tracking result or the COVID in broader terms, I must say that the 2021 budget statement, which was issued on March 12, 2021, allocated 5 billion, which is equivalent to 1.47 million to the health sector. When you compare this figure to the 2020 revised budget, this represented a reduction of 3.6 in real terms and a decrease in the health sector's share of the total government budget from 10.5% to a new 7.5%. The National Health Insurance Scheme provisional allocation for 2021 is somewhere around 1.9 billion, that is equivalent of 328 million. So clearly from the budget statement, 6 headlines stand out. The first one is there's a new earmark inflows as a result of the COVID pandemic. And this is to meet the needs of the COVID response. So the government introduced a COVID health levy that increased by 1% point the national health insurance levy. So it is now moving from 2.5 to a 3.5%, and a 1% point increase in the value added tax, which is really a flat rate, moving from 3% to 4%. At this point, it is, however, unclear from the budget statement how these expected additional revenues will be allocated. The government is also looking at plans to pursue massive health infrastructure development under the Agenda 111, an initiative which started in 2020, which aims to construct 101 district hospitals, 7 regional hospitals, 2 psychiatric hospitals, and rehabilitation of existing hospitals. So COVID has actually, government will continue to implement measures to curb the health and economic impact of the COVID-19 pandemic through a medium-term strategy. And so in this particular case, for the health sector component of this plan, provision has been made in the 2021 budget for COVID-19 health response. Government is also looking at innovation and information technology as a result of the COVID tracking as well as the COVID experience. This, what I call the e-health agenda, that is 7 million and 1.2 million of the Ministry of Health budget was allocated to e-health interventions. This figure is, however, half of the 14 million, which is 2.5 indicative ceiling for the 2021 of the medium-term expenditure framework. The budget statement highlights the government's interest in pursuing innovative interventions, such as the use of drones to deliver essential supplies and expansion of the logistics and then the supply chain management information. The National Health Insurance is also using innovative approaches such as mobile renewal to expand the active membership of the scheme. There's also a plan to develop institutions for health sector regulation and emergency response. The government in 2021 fiscal year will be establishing the Ghana Center for Disease Control and facilitate the passage of a legislative instrument to strengthen emergency response. And of course, there's also an attempt to improve supply and distribution of human resources. An amount of 231.2, that is 40.4 million, has been allocated to pay the nursing training allowance in 2021. In summary, I think the extent of the pandemic softened government position to allow the private sector to mobilize and use funds with limited restrictions. procedures, were relaxed, especially if we look at the World Bank procurement, so reallocation of resources. The lessons learned out of this is that the guidelines can be developed for emergency situations on how financial management systems can be shortened during pandemics. So there's a need for us to incorporate some level of flexibility in our financial management processes. Rolling out of gift mix, and of course looking at other program-based budgeting mechanisms can actually help in this direction. Once again, thank you very much for the opportunity for WHO to share the Ghana experience in terms of what the tracking has really pointed out to. Thank you.
À la suite de mon collègue du Ghana, je m'en vais vous présenter les résultats du Sénégal dans le cadre de l'évaluation rapide des dépenses de la COVID. Je me nomme Mme Diaw Thianégué. Je suis la coordonnatrice de la cellule d'économie de la santé qui est au ministère de la Santé et de l'Action sociale. Donc, nous allons axer notre intervention sur les défis, les leçons apprises et les recommandations. Par rapport aux défis, il fallait vraiment disposer des informations financières de façon exhaustive et désagrégée selon les domaines du plan de contingence, puisque ce plan a été validé et encadré par l'OMS. Donc, il fallait vraiment faire la répartition de ces dépenses par rapport aux 8 domaines qui ont été identifiés. Comme autre défi, il fallait aussi disposer des données financières du niveau opérationnel. Comme vous le savez, au Sénégal, nous avons 14 régions médicales, 79 districts. Et dans le cadre de cette riposte, on avait mis en place des comités régionaux de gestion des épidémies et des comités départementaux qui étaient présidés successivement par les gouverneurs et les préfets et sous-préfets. Il s'agissait aussi de capturer toutes les informations de toutes les parties prenantes parce que nous avons eu beaucoup d'autres secteurs qui ont eu à nous accompagner, comme les départements, les collectivités territoriales, le secteur privé, les PDF, les ONG, les mécènes et aussi d'autres ministères. Il s'agissait aussi d'évaluer les dépenses des ménages. Donc, selon une méthodologie que les comptes n'ont pas l'habitude de faire. Et évaluer aussi rapidement les dépenses de la riposte pour permettre aux autorités de faire des réagissements si nécessaire. Et aussi, comme autre défi, c'était d'établir une coordination efficace avec les différents niveaux du système du gouvernement sanitaire pour une bonne allocation des ressources. Et comme leçon apprise, nous avons noté une flexibilité des PDF et du secteur privé. Et la coordination aussi multisectorielle avec le One Health qui est une réalité au Sénégal, avec vraiment tous les départements du secteur de la santé pour la riposte et une possibilité aussi de mobilisation accrue des ressources domestiques. Déjà avec le secteur privé national, nous avons eu beaucoup d'aide et beaucoup de donations. Et la mobilisation de toutes les couches aussi de la population dans le financement de la riposte avec des dons en nature et en espèces. Exemple, nous avons l'appui des religieux, des marchands ambulants, des entreprises, donc des musiciens et ainsi de suite, etc. Aussi comme leçon apprise, l'implication et la coordination des autorités administratives et locales dans la gestion du financement avec les gouverneurs et les préfets qui étaient au devant de la scène. L'adaptation du financement des collectivités, des activités de riposte avec l'évolution de la maladie, car l'État et les PDF ont réorienté leurs ressources pour bien prendre en charge la pandémie. Nous avons aussi comme leçon apprise l'implication des populations dans le financement et la production de masques, de désinfectants par les entreprises locales. Aussi, comme leçon apprise, en moins d'un an, nous avons vu qu'il y avait beaucoup de protocoles de recherche dans le cadre de cette pandémie. Aussi, l'implication des collectivités territoriales aussi dans le cadre du financement a été très bénéfique. Comme recommandation, nous avons demandé une création de plateformes multisectorielles pour assurer la coordination et la transmission de l'information à temps réel, surtout l'information financière. Donc, la promotion aussi de l'archivage des données dans toutes les structures du système, parce qu'en moins d'1 an, nous devons vraiment avoir les informations de façon exhaustive. Mais il y avait quelques poches au niveau opérationnel qui n'avaient pas gardé certaines informations ou bien certains dossiers qui nous permettaient de faire la collecte correctement. Et l'implication de l'équipe des comptes aussi est nécessaire dès le début. Donc, dans la planification, le suivi et l'évaluation pour nous permettre d'avoir les données de façon exhaustive et aussi selon la méthodologie des comptes. Et aussi l'intégration des données financières dans le module tracker de la plateforme DHS2. Parce que dès le début, le Sénégal a mis en place un tracker qui permettait de capter toutes les informations techniques donc relatives à la maladie, mais il n'y avait pas de formulaire de financement. Donc, d'où la nécessité d'intégrer dans ce tracker-là les données financières. De partager aussi les résultats d'études avec les autorités pour l'utilisation à des fins de prise de décision. Donc, l'autorité a toujours besoin d'informations financières pour réajuster l'allocation des ressources. Et enfin, rendre disponible une liste de prix standard pour faciliter la valorisation des dons en nature. Parce que nous avons reçu beaucoup de dons en nature, mais chaque partenaire avec son prix. Donc, d'où l'importance vraiment de stabiliser ces listes standards. Donc, voilà, c'est ça l'économie de mon intervention. Merci, je vous en prie.
Great. Thanks very much to all of the speakers for this presentation, which was really important, and I think to get these country perspectives and quite comprehensive in terms of available data, shortcomings in the data as well, the direction of bias perhaps, and hearing about the policy issues arising. And also certainly that despite all of these countries being recipients of some aid, that it's domestic spending that predominates. So now we're going to change to our last set of presentations. And for this, we're going to start with Marianne Cross, who's a senior health economist at the Global Financing Facility, which is doing a lot of the work on resource mapping and tracking in the countries that they support. This will be followed by the work by Sean Cockerham from the Health Emergencies Program and the Health Security Preparedness Department at WHO here in Geneva. And then we're going to have two country experiences, one from Niger, looking at that experience, from Abubakar Chaibu Begu. And then last, we will hear from Ms. Amanita Nana, who's a specialist in PFM supporting the Ministry of Health of the Democratic Republic of Congo. So let's turn over to the video again. And a reminder, after this, we will have our live panel. So if you have questions also that you want to put into the Q&A, please do so, either for the panelists or for any of the, or reflecting on any of the presentations you've heard. So let's go to the next set of presentations.
Good morning and good afternoon, everyone. My name is Marianne Cross. I'm a senior health economist at the Global Financing Facility Secretariat. So today I'm going to start walking you through a presentation that my colleagues and I put together about expenditure tagging and strategic budgeting for COVID-19. So slide number 1, how does tracking resources of the COVID-19 response plan fit within health financing and budgeting systems? So I think it's important to make a differentiation between short-term and long-term. when we started supporting ministries of health to conduct resource mapping and expenditure tracking of their COVID-19 response plan, it was really, for them to address a few policy questions. Some countries wanted actually to understand whether there were a particular funding gap in some particular priorities of the COVID-19 response plan. Some other wanted really to see whether there is deprioritization of essential health services toward COVID-19. So it was a short-term need. But on the long term, I think it's important to ensure that all these COVID-19 priorities should be actually part of a national health strategy, well codified in the budget, or even well included, in the NHA classification at some point. Next. So just a bit of a background. So the GFF, in partnership with other development partners like WHO, so we support ministries of health through government-led, routine and institutionalized process. Ministries of health to conduct a resource mapping and expenditure tracking of their national health strategy. So the boundary is really the national health strategy, gathering budget, expenditure data that we compare to costed priorities of the national health strategy to improve the national health strategy alignment and donor coordination, because it's monitoring donor funding over time. Whether yes or no, they improve contribution toward the national strategy, to strengthen domestic resource mobilization for health and to increase efficiency. Next. So when we started supporting countries, conducting resource mapping for COVID-19 response plan, what we realized is that commitment and disbursements are very critical to a well-coordinated national health responses. But all countries actually faced challenges in designing and in implementing resource mapping and expenditure tracking of COVID-19 response plan. There were countries which had an established sector-wide resource mapping and expenditure tracking. And they already had existing data on emergency preparedness because some of their national health strategy had an emergency component, but often within the health sector only, and it was not really, a resource mapping which was actually multi-sectoral. So it was actually important to strike a balance, either trying to use this existing tool for resource mapping expenditure tracking and integrate some COVID-19 priorities, related priorities, or to develop a very separate tool specifically on resource mapping expenditure tracking for COVID-19 response plan. It was perhaps faster, but it looked a bit more verticalized approach and not very well integrated into the existing resource mapping. But at the end of the day, it all depended, on what the countries really wanted to do and the timeline they had. Another issue was the fact that countries without actually established resource mapping and expenditure tracking did not necessarily have the capacity or even the bandwidth to start multi-sectoral resource mapping and expenditure tracking across, of COVID-19 across sectors. And I'm sure that Sean will talk toward that. So, as a result of these challenges that several countries faced when developing a resource mapping and expenditure tracking exercise for COVID-19 response plan, so we, the GFF, with several partners, we decided to develop a guidelines not only to tell them how the tool should look like, because this is pretty straightforward and easy, but more to tell them how to design the tool based on the policy question they really want to address with this resource mapping expenditure tracking exercise. And as I said earlier at the beginning, there were a few countries who wanted to have this exercise really to assess whether yes or no there has been deprioritization of from essential health services toward COVID-19. They wanted to understand whether there is reprogramming in their budget from essential health services funding toward COVID-19, and based on which they decided to design a particular tool. The second use case was really to do a resource mapping and expenditure tracking of COVID-19 response plan in order to assess where the funding gaps are in particular, so that they have the data to justify more resources when they go to ask for more resources at the Ministry of Finance, or whether they have as well to ensure they have the data, the justification when they go to ask for more resources to several donors. The third use case was really to improve allocative efficiency, and this is really something that Aminata will walk us through when talking about the DRC. And the fourth one was really to support the implementation of the COVID-19 response plan. In particular, it's not only about collecting budget data, but as well gathering expenditure data to see whether yes or no the priorities are being implemented. So expenditure is kind of the only data which provide information on the implementation status. Next. Despite all this positive development, at least in the GFF countries, we noticed that 12 countries have implemented a kind of a regular yearly COVID-19 resource mapping. But despite all of that, there is still a limited number who have such exercise and which is really integrated into their routine. And so it really makes it difficult to measure whether the COVID-19 response has been effective or equitable to inform policy. What we notice is that usually when the Ministry of Finance is involved in those exercises, there is the results come a bit in a faster way and are more used as well for policy purposes. So now I will give the floor to Sean to continue and walk us through a multi-sectoral example of RMET of COVID-19 response plan.
Hello, everyone. My name is Sean Cockerham, and I'm Resource Mapping Focal Point in the Health Security Preparedness Department at WHO. One reason that resource mapping during COVID is so important is the vital need to ensure that the investments that are being made to fight the pandemic are also contributing to building longer-term preparedness in the country. As this slide shows, the pillars of the COVID-19 Strategic Preparedness and Response Plan are closely connected with the technical areas of preparedness building national action plans for health security. WHO analysis has shown that nearly 85% of the actions in the COVID plan can lead to sustained health security preparedness capacities if they are built upon and invested in. Our resource mapping is meant to foster collaboration between the government and partners of preparedness for COVID as well as beyond. So we first started using the WHO REMAP tool in 2018 for resource mapping to support implementation of national action plans for health security. And we've since expanded to include resource mapping for COVID-19 as well. Through REMAP, we work with the different ministries and partners to map the activities and investments, both at the national and subnational levels, and show where the needs are and the gaps are. We highlight areas of potential collaboration between the country and the partners, and we bring them together to discuss collaborating for implementation of country plans. The objective of our work is to use our resource mapping data to promote dialogue between countries and partners, to establish multi-sectoral partnerships for health security, and to enhance country ownership of health security planning. We currently have resource mapping data collection exercises ongoing in Guinea and Liberia, with Indonesia and South Sudan among the countries that are in the pipeline and expected to begin their resource mapping soon. Our approach is to connect the national activities that have been prioritized for implementation with the financial and technical resources that are available for implementation. This is done by gathering data on domestic investments, on existing partner investments, and on potential partner investments, thereby identifying gaps and potential resources to support these activities. Many countries, of course, require expertise as well as financial assistance to implement their health security plans. This is why through resource mapping, we also work very closely with country focal points to identify country needs for technical assistance, whether this be trainings, specialized expert guidance, or other assistance. This data will be used for the Global Strategic Preparedness Network, or GSPN, which WHO is establishing to coordinate technical assistance to countries and help them build back better from the pandemic. GSPN was mandated by WHO member states at last year's World Health Assembly and will help to build public health workforce capacity and end the cycle of panic neglect that characterizes pandemics. The objective is to support longer-term preparedness and to ensure the sharing of experiences and best practices between countries for stronger preparedness in the future. Last year, in the context of the pandemic, we began a partnership with the Global Financing Facility, working closely together on resource mapping to support implementation of COVID-19 preparedness and response plans. In Niger, for example, we worked with the GFF team to design a joint data collection tool. We look forward to working further with GFF and also with any countries that are interested in resource mapping for health security. I will now turn it over to my colleague from Niger to discuss the results of the Niger mapping. Thank you very much.
Merci beaucoup. Je me nomme Aboubakar Cheboubegou. Je suis l'officier de liaison pour le mécanisme de financement mondial JFF et je suis très heureux de partager avec vous notre expérience en matière de cartographie des ressources. En effet, le JFF et l'équipe de sécurité sanitaire de l'OMS ont travaillé en étroite collaboration au cours de l'année 2020 sur la cartographie des ressources mobilisées pour soutenir la mise en œuvre du plan de préparation et de riposte à la COVID-19 au Niger. Sur un total de plus de 27 millions de dollars provenant des sources extérieures qui ont été mobilisées pour financer les 6 piliers du plan Covid. La moitié a été consacrée au renforcement de capacité des services de santé en matière de prise en charge des malades. La surveillance épidémiologique vient en deuxième position, suivi des piliers liés à la communication et à la prévention-contrôle de l'infection. Sur un total de plus de 30 millions de dollars recensés, provenant à la fois du financement externe et du secteur public, 11 millions ont fait l'objet de reprogrammation à partir des budgets initiaux, soit le tiers du financement, naturellement au détriment des services de santé initialement prévus dans des activités de santé de la mère et de l'enfant. Une analyse détaillée des ressources mobilisées révèle que les 2 tiers proviennent de 6 nouvelles sources, avec en tête la Banque mondiale, le Fonds mondial, l'OMS, et 9 sources de financement ont dû procéder à des reprogrammations sur leurs budgets initiaux pour un montant de plus de 11 millions de dollars. Le déficit de financement du plan de réponse à la COVID en 2020 repose essentiellement sur 3 piliers, à savoir le pilier prévention et contrôle de l'infection, le pilier capacité des services de santé en matière de prise en charge des malades, et enfin le pilier concernant les sites d'isolement pour le confinement des cas positifs. Je vais laisser la parole à Aminata qui va vous parler du cas de la République démocratique du Congo. Je vous remercie de votre attention.
Bonjour à tous, moi je me nomme Nana Aminata, je suis consultante auprès du ministre de la Santé de la RDC et donc j'accompagne la mise en œuvre du tracking des dépenses COVID-19 pour aider à la prise de décision. Comme message clé que nous pouvons retenir de notre exercice de tracking, c'est le fait que la pandémie de COVID-19 a entraîné une dépriorisation de certaines dépenses essentielles de santé au profit de la prise en charge de la maladie de COVID-19. Et donc, on verra déjà qu'en avril 2020, la proportion des dépenses de santé qui a été abandonnée et orientée vers la prise en charge de COVID-19 était environ de 8%. Et cette proportion a continué à s'augmenter, de sorte qu'en juillet 2020, nous sommes passés à 38% des dépenses de santé abandonnées au profit de la prise en charge de COVID-19. Cela a montré que certaines dépenses essentielles pour la prise en charge de la santé de la mère et de l'enfant ont été abandonnées du fait de l'apparition de la COVID-19 et donc de la nécessité de reprogrammer les dépenses. L'autre élément que nous pouvons retenir, c'est le lien entre le financement de la COVID-19 et les cas de malades enregistrés par province. Et donc, vous allez constater déjà que les 5 provinces les plus touchées à l'époque par la pandémie de COVID-19 sont celles qui ont bénéficié effectivement des ressources pour la prise en charge de cette maladie. Et donc, la province de Kinshasa, qui enregistrait 80% environ des cas de COVID-19, a bénéficié de pratiquement 90% des financements qui ont été mobilisés à l'époque pour la prise en charge de cette maladie de COVID-19. Donc, c'est pour dire que la pandémie de COVID-19, le tracking a été essentiel et a aidé à la prise de décision pour que déjà en 2021, le gouvernement sache quelles décisions prendre sur la priorisation des dépenses et éviter que certaines dépenses essentielles de santé ne soient abandonnées au profit de la COVID-19. Donc, je vous remercie pour votre attention.
Great. Et merci à vous, les speakers. And now we're going to turn to our live discussion. So we will have people who are really in the virtual room able to share their views. And we're going to start this with a bit of reflection from our 4 panelists. And we're going to start with Dr. Parfait Uwalirai, who serves as the head of planning, monitoring, and evaluation and health financing in the Ministry of Health of Rwanda. So Dr. Parfait, can you start us off with some initial reflections on what you heard, how some of those issues manifest themselves in your country and so forth?
Okay, can you hear me now?
Yes, very good.
Okay, so I would like, I was saying I would like the presenters, our colleagues have presented on this important topic about out tracking the COVID expenditure across countries. So as Rwanda, especially this time of COVID, this topic or tracking COVID expenditure was very, very an important things because as you also mentioned by our colleague, COVID, there have been a lot of resources spent. They need also to understand where the resource has been spent, why it has been spent, and also trying to understand how we can learn from the way we are allocating resources, but at the same time spending them. So just wanted to share with you the case of Rwanda on the same topic. We normally have an already system that captures expenditure on health across the sector. It captures government, different sources, government, private, partners, insurances, but also any other spending that is happening on health in the country. So COVID was also part of this exercise of capturing the data as well for the expenditure. So the information that were collected according to the structure of our COVID response plan. That was already organized in different thematic areas, the coordination, continuity of health services, data management, epidemiology, surveillance, and also point of entry, laboratory, case management, IPC, operation support and logistics, risk communication, and community engagement, but as well the vaccination. So resources were mobilized from different sources. Governments, that was the main funder of the response, but also partners. It was mobilized either in terms of cash or money, also in terms of kind, let's say testing kits, PPEs, and any other equipment that's that supported also the response. So, as a matter of accounting the accountability data, the budget, the way it was been spent, there has been regular meeting through various police dialogue forum, or one head by the Minister of Finance, because we didn't, the COVID expenditure happened in different sectors, let's say health, social protection, but also in any other sectors. So the Minister of Finance on regular basis, every quarter, there have been a meeting where the Minister of Finance presented all stakeholders, including TPs, about the expenditure on this COVID. And also the same apply to the health sector as well through our coordination mechanism.
Now, do you hear me?
Yes.
I don't hear you.
Can you hear me?
Yes, we're hearing you, Parfait, but we need you to wrap up so that we can go to the next panelist.
Okay. So thank you very much. Yes. So the plan, or we're just focusing, also helping us on the planning. I mean, the expenditure, the information help us on the planning, but also future allocation of resources, but prioritizing the health financing, the workforce, the quality of service, also continue provision of essential services, but at the same time ensure that we have the information information system to produce high quality data in timely manner. So in brief, that was just how we track the response and how the data has been used, and for that specific purpose that I highlighted before. So thank you very much, Joe.
Good, thanks, Parfait. And it's very important, I think, as we're hearing from you and others, that that it's clear that this is being done for a reason, right? And to really help inform decision making. So I want to turn back now to Chris Kuchak for any further reflections from you, Chris.
Yeah, thank you, Joe. Very quickly, just what I wanted to go back is my point about how COVID amplified pre-existing trends, and I'll give you a couple more examples. In Canada, well, in many OECD countries, we've been talking about the impact of population aging for a number of years, and thinking about how to best provide care for our seniors, whether it be in long-term care facilities, home-based long-term care, and even long-term care beds in acute care facilities. And so, COVID really hit our seniors hard in our country. And so I think going forward, there will be a lot of emphasis on how to deliver care to meet the needs of an aging population. And that was a pre-existing trend that was amplified. Another one that I will flag is virtual care. Telehealth and telemedicine existed before COVID, but what we've seen is really ramped up the use of that out of necessity, because people couldn't make in-person visits. And it'll be interesting to see how investments in technology and in the infrastructure, as well as even just issues around equity and access will be an issue, in addition to the spending and investments. So I'll stop there, but I just think those were a couple more examples of pre-existing issues that will just continue to be coming to the forefront in the future. Thank you.
Thanks a lot, Chris. Really, really helpful and important points. And I think this is something relevant to countries around the world, actually, is that this, there was something there beforehand, and really needing to put the spending patterns and use patterns that we're seeing now in that wider context. So I want to turn now to Ellen Vanderpoel, who's a senior economist with the World Bank and works at the Secretariat of the Global Financing Facility. Ellen?
Thank you, Joe. Can you hear me well?
Yes, very good.
Okay, great. I'll be very brief because a lot of interesting things have been said. I don't want to repeat. I wanted to just sort of summarize perhaps what I've heard from Juliette's presentation, and very much resonates with the work we've been doing also with the GFF in collaboration with the WHO, that resource mapping and tracking is not the need for that is not created by COVID. It was there before, but sort of the COVID pandemic made it very acute. We saw in many countries that the COVID response plans, the cost of those represented actually a substantial share of the national health plan, so very sizable cost. And we know that this is happening in the context of already a severe underfunding of a lot of these national health plans. The work we've been doing in the GFF sort of shows that in quite some countries, a funding gap of 50% behind the national health plan is not uncommon. At the same time, the COVID response was heavily in many countries initially funded by donors and not with all new money. There was quite some reallocations away from other essential health services. So all of this, both the underfunding, the acute need, and the repurposing away from essential health services really creates an urgent need for us to look very critically at the funding that is available, the priorities we should spend it on, and make sure that countries make very rational choices, because going all in on COVID at the expense of other services, of course, is not the most rational thing to do in terms of improving health outcomes either. So I just wanted to make that point very, very salient. I wanted to reflect on four, sort of briefly put out 4 key messages for sort of the work going forward. I think it's important that we not only look at the amount of resources that are allocated or spent on certain priority areas in terms of the COVID response, but also look at the way this money is being disbursed and used. There's a real risk, I think, of sort of the COVID pandemic now further verticalizing the system and the way we sort of look at the fund flows. And it's really important we don't allow that to happen, because it is likely COVID will stay with us for quite a while, and the services provided sort of are delivered through the same platforms as other services. So just a plea to avoid any further verticalization and try to do all of this mapping and tracking work in an integrated way. And second, I think it's important that we sort of look at this mapping and tracking of fund flows in a way that is very much in relation to programs and targets. I appreciate the National Health Account exercise sort of creating clarity on important priority sort of areas, and also in a way that's comparable over time and across countries. But I would argue that it's also important to look at certain targets that relate to a reform agenda in country and that we can help monitor. If, for example, in relation to free user care schemes or whatever is relevant at country level, I think that's the way we have to tailor a bit these mapping and tracking exercises. When you do that, I think these sort of exercises also really provide an entry point for a larger work program on public financial management, because then also you immediately start to see that the way money is being allocated or spent is not always in relation to the priorities laid out in such a national health plan. And then finally, I just wanted to add that I think sort of again, this national health account exercise is extremely important, but what we saw also in this pandemic time, that you often need very real-time and frequent data, and also prospective data on that to sort of inform a policy dialogue in a very timely way. And so here is where I think sort of the way it shows national health accounts work very much complements the work we've been doing with GFF on the more prospective real-time resource mapping and expenditure tracking that can provide a sort of quick and dirty analysis of what is available and how it is being spent, and can then at a later stage link to a national health account exercise that has a more granular and more cross-country comparable approach. So let me end here. I thought these were just points that I thought would be worth making in addition. Thank you.
Great. Thanks a lot, Ellen. And last, I'm going to turn to Anya Suka, who's an economist and medical doctor. And I'm getting used to saying this now, or I have to now, as the head of Health and Social Protection Division of the Agence France de Développement, where she's overseeing health and social protection investments in 115 countries. So Anya, some reflections from you, please.
Thank you, Joe, and thanks for an amazing session. I learned so much from it, and thanks to all the panelists for the incredibly rich information. I must say that as a first reflection I must say that I was actually surprised that we were already so advanced in having a sense of the COVID spending. So that makes me very optimistic about the annual global report on health spending to come in December. That we will have more to say than we had last year. Even we are still we still don't have, we will not have the expenditures, the full picture of expenditures for 2020 that we will only have in 2022. But I was really impressed on how we are approaching that question already, and that we already have some really good level of information on that. And I really want to commend and congratulate both the OECD and the WHO, NHA, and health financing team. What was presented from the Africa region was nothing but spectacular. I mean, very impressive. So for me, that's the first lesson: is that actually we've gone a long way. We were not able to do this kind of work 10 years ago. So we can see that the capacity to analyze expenditure and to do expenditure tracking at country level has really improved, and we need to continue to invest in that, and we need to build capacity. The second reflection is really the astonishing message, I mean, the amazing message, not surprising, I think, for all of us that work on public financial management, that actually most of the response is actually coming from government, and is coming from domestic spending. And I think it's really, there is a message there, and we need to think further of how we think about expenditure tracking in global health, and that we probably need to be more careful as to the balance between investing in heavily in tracking commitments of donors, which at the end is a pittance in the response, and we put a lot of energy and a lot of capacity there, whereas we put much less in actually building the capacity of countries to monitor the domestic spending and doing it in a way that is useful for policy making, which is the objective of having very strong teams at country level who can really document national accounts, including national health accounts. So that sort of PFM capacity building at country level is absolutely fundamental. And then my third reflection there is that it's really impressive. This is the presentation of OECD, but also of the different speakers from Africa about the difference between countries. And it really, really gets us to the point that we really need to have country data, and that the way it is sometimes done, that we could model this kind of thing, is really not the way forward, because countries really profoundly differ in the way they respond to such a crisis. There's such a variation. I mean, just the fact that some increase and some don't increase, the fact that we still don't really know what are the drivers of that. So it's very interesting to have, for example, a hypothesis that it depends on payment systems, that depends on the share of the private sector. It's really fascinating to see that there is this public spending response in many countries. And that the only way that we can actually have policy relevant information is actually to have real numbers, and that we need to further invest in that. And I think it's really interesting how it has been approached by the different teams. And of course, I am biased. As everybody knows, I'm a huge fan of national health accounts and country data. But I think we really need, as the global community, to start to shift away from that narrow focus on aid and mobilization of external funding, to actually understanding the full picture and building the capacity of countries to do to do expenditure tracking rather than to serve an increasingly small pool of global health actors. So that's really for me the third lesson. And to respond to one of the questions about the capacity of government to mobilize financing, I think the question is no different from what it was before the crisis, right? About the fiscal space. I mean, this is the question of fiscal space, and we know that the response is actually the crisis was very well said by OECD, has just highlighted the underlying clay feet and weaknesses of systems. We see much more prominently what were those weaknesses, and most governments have actually responded incredibly well. And I would say the global community, when it comes to financing, has responded extremely well by really making all the rules more flexible, going for very large amounts of transfers, for allowing countries to, deepening deficits, having counter-cyclical policies, some of them really trying to adjust either through the regular budget or many through supplemental budgets. This is a mine. I think by next year we will have a whole new step, really a leap forward on our understanding of the response of countries to a major fiscal crisis that is so sudden and so global in a way that all countries were affected. Which is quite rare. So that's really so that's the response to the question of government response. They did respond. So it's not a theory. Governments did respond. Governments did spend. They did not always spend on health activities. They spent to support households through cash transfers. They spent in opening lines of credits for small businesses to survive, but they did spend. I mean, we've been in a year of massive fiscal transfers, in a year of both within national boundaries and within international boundaries with the intervention of international financial institutions. So that's not whether, it is the how that we need to analyze, and which instruments have proven to work vis-a-vis those that have not proven to work. And the role of actual direct external grants has been quite limited. I mean, the numbers are just different. They are just a completely different orders of magnitude, because when we talk about external transfers, we talk in billions, and when we talk about domestic response, we talk in trillions. So that's really the key point. Over.
Great, and thanks. Yeah, and on that, I know that you referred to the presentation of Juliet and team in Africa, and that showed very clearly, I think, in many of those cases, that the domestic response was much more significant at country level than the international inflows. But on this question, and maybe for some of our country panelists, Chris and Parfait, Agnes pointed to, for sure, in the current year, it hasn't been a problem for countries to go into deficit spending. I think, Chris, you were referring to a little bit the longer term perspective on that. We heard in one of the cases in Ghana where they've actually introduced some new revenue raising instruments as well. But maybe, Chris, you have some reflections on this, and perhaps Parfait as well?
Yeah, absolutely. So fiscal sustainability, again, was an issue that we talked about before COVID as countries were running deficits. I think what we're seeing here in Canada is really not so much of how much more do we need to spend in the future, but rather how can we do it differently in order to get, to meet the needs, but in the most effective and efficient manner. So when we think about, areas that I think in the near term, in the short term of focus for policymakers will be on, of course, health system capacity. And when we talk about capacity, it's not just number of hospital beds and physical infrastructure, but you have to remember it's the health workforce, the frontline workers that were at the front of care, delivering care. And so how much, getting the health workforce and investing training in development, and also in some countries you have an aging workforce, not just an aging population, but an aging health workforce. So that's an extra challenge. Another sort of key issue to monitor longer term is, this whole issue around potential adverse health outcomes in the future of canceling elective surgeries. Is that going to mean, worse health issues to have to deal with in the future? And mental health, that'll be another one going forward. So I think there's short-term priorities around capacity and longer-term issues that will have to play out.
Yeah, I mean, it's really this challenging trade-offs. And I think it's, as I think you were saying, and I think the others would agree, it's not just how much, but how that spending works that matters. I don't know if any of the other panelists, Parfait, did you want to come in on this from your country experience, or Ellen, also some reflections?
Just type. Oh, sorry, Parfait, go ahead.
Parfait, maybe you first, and then Ellen.
Thank you very much, Joe. Just wanted to reflect on what has been asked by our colleagues. In our country, the way the planning, we of course with the experience of COVID, how we managed to plan, also put up strategy to build a resilient system, of course, in the context of this COVID. So there has been some key strategy that now we are trying to we have discussed and not trying to see how we can better implement them. Number one was the issue of prioritization, increasing prioritization for the health sector within the overall budget, government budget. And this I've seen it's very, very possible, especially in the context of COVID. And number two, I mean, the same line of increasing the resources. We wanted also plan to create a health financing mechanism that are less or not affected by shocks, especially trying to see how can accumulate reserve within the health system. The second point was the availability of workforce, increasing or training more or specific cadres that are needed to respond to specific demand in the sector in terms of service provision. And another element or another strategy that we have developed, it was about see how we can maintain the delivery of essential health services, especially in the event of shocks. This goes with a long-term strategies that wanted to strengthen the capacity of the community health worker system to improve the way they are delivering care at the community level, either in developing or reviewing the service package that they are providing, especially respond to the need of the population, either building the capacity, their capacity to deliver the defined service package, but also trying to design an effective package for them, and at the same time strengthening the management of their cooperative. So those are the things, the key strategies we have tried to think through, but also now trying to work on and see how we can strengthen them or implementing them better, especially in the event of shocks with COVID that we are now facing. Thank you very much, Joe.
Thanks a lot. Issue close to my heart when we think about these issues around how to have financing arrangements in particular that are resilient to employment shocks and formal employment shocks. But let me turn to Ellen.
Thank you, Joe. I just wanted to add one point in relation to what we just discussed, is that that indeed the situation is very different across countries. What we've seen in with the GFF work, because that's mostly focused on low-income countries, is that it was the case that in the countries we have data for, on average, the COVID response plans initially, that might have changed, but were funded for 90% by external resources because of the very limited search capacity in some of these countries. And at the same time, external resources did not increase proportionally. So it does mean that there's a substantial reallocation of these very limited funds. Now, again, I think increasingly governments have picked up these costs, but with that same caveat that there is a repurposing, because there is, like I said, we are working in a context of underfunded national health plans in the first place. So I would sort of just want to underline again the need, and I think that's where the big value of these exercises really lie in, the need to be very rational about what the next marginal dollar should be invested in when you're on an extremely tight budget constraint, especially because in many of these countries, the COVID context was also quite different from middle-income countries. So just another call for looking really at the budget constraints whenever we do these plannings and prioritization exercises. Over.
Well, I would imagine as well, and it came up in one of the earlier questions about the flexibility within the PFM rules to actually reprogram in such a way, to kind of operationalize that idea of kind of being able to spend the next marginal dollar where it's needed. Right? Would that be also one of the issues we'd need to be looking at?
Exactly. I think that's why we had a lot of donor-funded initial response, because of that rigidity, which creates a huge inefficiency, because at that particular point in time, of course, there was a need to respond to the pandemic. Right. So yes, exactly.
Great. There's another question in the chat box, and I'm not sure, or in the Q&A, and I'm not sure there's a right answer to this one. Is there a reasonable ratio between, and I'm guessing the intent here is between the allocation, for the new funding related to COVID and the existing funding? I mean, there's probably not a lot of historical precedent, but anyone want to reflect on this, and perhaps in particular for how health expenditure data could help address this type of question? And how you're looking at it in particular countries or across countries? Or does it or is the answer simply it depends on the country? Anyone want to bite on that? Chris, go ahead, please.
Well, I'll just start the conversation. I think definitely country variation plays a role. This is why having the value of having international data to compare, because different countries had different experiences at different times, and how they responded to the pandemic was different. And that's where we then, again, it was an emergency response. That was the primary objective. The finances and the funding came afterwards. Right. And so, but going forward, the challenge will be separating out, okay, what were the temporary emergency response funds that are expected to expire or diminish, and then how do we invest in evolving the healthcare system to improve capacity, better respond to meet the needs in the future? And I think it'll be an evolution. I don't think there's one ratio, but again, for many, the pandemic is not over yet. And right. We don't know what variants and other waves will happen. So I think it's still very much emergency response in the near term, and then longer term, how do we pivot to respond so that in the future we don't have to be locked up in our rooms here doing this all the time, when we can do a little bit more open economy and seeing each other in person. So I'll stop there to start the conversation.
Yeah, thanks. I mean, for most of the world, indeed, it's not, we're not thinking post-COVID at all. I mean, it's still very much a real thing for the time being. Agnes, did you want to come in on this point as well?
Yes, very much so, and I totally agree with Chris. But the fact is that, in a way, the traditional debate, the way it's been framed before the crisis, and particularly the way it's been framed during the MDG era, is not very useful anymore, because we we are in a major crisis that is not going to go away next year. It's pretty clear. And we're also entering an era in which all the signs are that we will have major impacts of climate change that will impact public expenditures in a big way. And that in many ways, I mean, first we have a situation that is a kind of post-war situation in which you've run into major deficits and basically you have the potential of a post-war boom, which we observe somewhat right now in OECD countries. But at the same time, we have a unique situation, which is that the most likely scenario is that we're entering an era of permanent crisis. And I'm sorry to say that because I'm a very optimistic person and I'm trying to see things positively. But I don't think we can say, well, in 2 years from now, we're back to normal and we're going to go back to budgetary orthodoxy. And no, I think we clearly, we have had in 2020 a validation of Keynesian policies and counter-cyclical policies using the public spending instrument and running public deficits. It's made a major difference. I think we can see it everywhere. But thinking that we may have a scenario, a post-World War II scenario, I think is overly optimistic. So it's not going to be easy because we really have a unique situation. Currently, we have a situation of excessive liquidities, excess of capital globally, but at the same time, we have serious problems of debt sustainability in low-income countries. We have debt that has increased in high-income countries. And there is the question not as to whether we're going to manage that debt through inflation, combination of inflation and growth, or whether actually we will have to really think very creatively because we will have major other crises to manage. And having just started a whole new position that is incredibly exciting because I work a lot with other sectors, in particularly environment and climate change and biodiversity, the kind of climate shock that we've seen in Madagascar with the drought, the climate change drought and famine, this is something that is almost sure to happen in Europe within the next few years, right? That's like a major climate event. You're living through one of them right now in Canada. So I think it's just, we really, and that's why it's so important to analyze what happened last year and because countries behave differently. They use different instruments and we have a fountain of knowledge because countries reacted differently, they were under different stress. And I think the NHA of next year are going to be absolutely fascinating in the analysis of these data in relation to policy analysis. I think we're really looking forward to all the academic centers in the world to really look at that, because that's going to be information that we will need to respond to future crises.
Great, thanks a lot. I was going to say thank you for more or less finishing the panel discussion on a happy note. But we do need to face that reality.
We are all doomed, isn't it happening?
Yes, no, we're not going to say that, but we are. I think what is important is, especially in terms of the context of this session, is precisely that these data become critical foundations for informing future decisions, and future, I mean, as soon as next year, right? In terms of this, because we do need to understand both the response, where the spending has gone, where it's coming from, the mixture of kind of the issues in terms of short-term response and building for the future. I think one of the things it brings out, maybe just to try and summarize and wrap up so that we finish more or less just only 10 minutes late, is this point that, okay, the health expenditure data and the health accounts framework, the SHA 2011 framework, provides this foundation. But I think two issues around this. One is that it's not to be used in isolation from other data. So we heard about whether it's public finance data, and Agnes was just referring to debt sustainability issues, whether it's obviously, as we often do, with service use data as well, and really understanding what's happened to other services besides those directly related to COVID, right? So there's some really important issues there. And the other part, I think, is the SHA 2011 framework, the classification are really important to give us a common language, but we don't use it as a straitjacket to limit our use of our ability to adapt, right? So we know much of the spending that needs to be looked at for broader public policy is spending outside the sector, whether that is about dealing with the social consequences or economic consequences of this, employment consequences and so on, or some of the preparedness and common goods agenda that is outside of the sector. And I know that's part of what's being done in the work. And I think if we can remember all the way back, I think to Shuka's presentation at the beginning, putting that frame together, that we're looking both within the traditional SHA 2011 categories, but beyond them as well. So I think that's important. In terms of some of the other challenges, I think on the data side, and it has come up in this talk, or in this session, certainly there's the issue of the timeliness of the data and the trade-offs between wanting to get things fast and wanting to get things accurate, and how we can improve that. There are things that I think in much of the world that's been doing national health accounts, areas that need more attention and maybe more disaggregation. I'm thinking of capital in particular, which certainly needs more work. And then also thinking about some of the specific issues that have arisen with COVID, such as the creation of special funds, off-budget funds, for example. And then some of the challenges, I'm trying to recall who had shared this, but one of our speakers mentioned the difficulty of getting household data. I think Juliet talked about this, that probably our household expenditure data was understated, and just the difficulty of, we can't do traditional household surveys in this era. And there's, I know, a lot of work being developed on mobile phone surveys and so forth. So there's a lot of challenges. And I think the work of the people who presented, the panelists, many of those who are still with us attending, really is critical for providing that kind of foundation that can lay the basis for better decisions in the future. So with that, let me just thank all of the speakers, presenters, panelists, and all of the attendees and the organizers as well for helping cope with the shocks that existed to the electricity in Canada, wherever that would be. And we showed some degree of resilience ourselves, so I appreciate that from everybody. And I'll just thank everybody again and wish you a good morning, afternoon, or evening. Thanks very much, and bye-bye.